Dear colleagues, it's a great pleasure for us to welcome you tonight to the UEMS section of surgery webinar on the topic incisional hernia prophylaxis, new data and guidelines. This topic has two aspects. The one aspect is, do we need prophylactic mesh placement in abdominal wall closure? And the second aspect is, should we use large bites or small bites in the closure of the fascia? This is a very hot topic right now in abdominal wall surgery. It is a great honor for us to have one of the most respected abdominal wall surgeons worldwide with us tonight, Professor Dr. René Fortelny from the Sigmund Freud University in Vienna. He is a board member of the European Hernia Society and was also Congress President for the European Hernia Society at the annual meeting in Vienna. He's an active scientist. He has published more than 128 publications listed in PubMed. He has more than 8,500 citations, and he has a Hirsch factor of 38. He has just published a randomized controlled trial comparing small bites versus big bites. He will surely present us the outcome of this study. And he also was involved in the group who created the new guidelines of abdominal wall closure. So René, you are very much welcome tonight. We have more than 300 participants, and I think it's a very good audience for you to hear your experience on the abdominal wall closure. René, hello.
Thank you, dear Ferdinand, for the nice introduction. Ladies and gentlemen, it's a great honor for me to present now my data, not only already mentioned from my study, but also to give an overview for prophylaxis, means mesh placement. And of course, I will show you a short video with the details of closure technique. And yeah, I would like to start now. Okay. I have to look second. Now. Yes, okay, it works. I would like to start with the risk of incisional hernias. So of course, you know that there is a relationship between aortic aneurysm and other abdominal wall hernias regarding risk of incisional hernias after AAA repair. If you look at the literature, we find about 30% or more. And the other group is the group of obese patients with a BMI at least of 27 and more. And you find their incidence of incisional hernias after 12 months of at least 22. And you see the total incidence will be at the end above 30%. So this, we know exactly, these are both groups. Of course, there are other groups, but we have a lot of evidence about these two groups. Looking at other experimental studies regarding the tissue perfusion and collagen synthesis in midline closures, these are all papers coming from the group of Aachen. You know, maybe Professor Schumpelik, this was one of the mentors of the wall surgery, and out of the group, Höher published several papers to that point. So if we look at that, this is a summary. Interrupted suture technique causes a decreased tissue perfusion with a persistent inflammation and leading to a significant adverse effect on collagen synthesis and wound healing. That means you have less collagen deposition at the end, the scar situation, the midline closure. The other thing is, out of the different studies, we know that the suture to wound length ratio of 4:1 or higher achieves a faster and decreased collagen synthesis, again, leading a stable scar. Then, of course, we know that a high tension may be not a good option for the closure technique, and therefore the interpretive monitoring of the suture tension is one of the key situations to have a perfect closure technique. So what should we prevent? Just one slide to have really the key parts of the closure. High tension, you should prevent the high tension of the suture line. You should prevent mesh closure technique, means all in one stitch, and at the end, the large bite technique. I come to the point later on. So what means high tension? Looking to this picture, you see the defect already immediately after the closure of the midline. You see the arrows, the blue arrows leading, showing the defects already a few minutes after closure with a high tension. And these so-called buttonholes are, of course, our origin for complications. At the worst case could be the burst abdomen. You see that on this slide. So what we know about the suture tension, if you do that intraoperatively and look at this point, then you have two papers coming from Germany, which were testing the closure, the approximation of both sides intraoperatively in incisional hernias. And you see if you have less than 1 kiloband, you can do a primary closure by suture. If you have more than 1 kiloband, then you should use a release technique, means component separation. So keep this in mind, 1 kiloband is the benchmark of high tension. So what's about the clinical evidence? I would like to start with the inline systematic review and meta-analysis published 2010 by Markus Diener, an analysis of surgery. And you see there were included 14 RCTs, more than 7,700 study patients. And summary, if you look at that, incisional hernia rate, if you compare continuous versus interrupted, it was, of course, significant, 8.4 versus 12.6. Then the suture was slowly versus rapidly absorbable, 8.1 versus 10.8. And absorbable versus non-absorbable, 6.1 versus 26.3. So in summary, out of this study, of this meta-analysis, 2010, was quite clear. The running suture by use of a long-term resorbable suture material should be done. And the author stated, no further trials should be conducted for evaluation of technique and available materials for elective midline abdominal fascial closure. But is this true? Of course not, because there's one of the biggest discussions nowadays. Should we use a large or a small bite technique? And if you look at this point, there is a review published by Nadia Henriks in 2018. At that time, we had only 2 studies, and you see randomized controlled trials, but another meta-analysis were included 23 RCTs, and you see the conclusions out of this match review was there's no high quality evidence available regarding best suture material or technique, but continuous suturing technique by small tissue bites with slowly absorbable suture significantly reduces the incisional hernia rate compared with a large bite technique. And the subgroup analysis, I already mentioned, there were 2 studies by Milburn from Sweden, 2009, and the stitch trial by Eva Derenbeck, 2015. And if you look at this forest plots regarding incisional hernia rate, there were 9.45 versus 19.30. Regarding the infection rate, there was no significant difference seen, 12 versus 16%. But what's about the discussion regarding the suture material in midline closure? Does this really have an effect on the incisional hernia rate? You see, this is a paper by Albertsmeyer, published 2012. And you see there was a comparison between the new material at that time on the market, coming on the market, Monomax, this is a poly-4-hydroxybutyrate versus polydiaxanone, this is PDS and Monoplast. They were the common used suture materials used in in the midline closure. So if you look now to the elongation, means elasticity of the material, where you find 90% in the monomax group, BDS and monoplus only up to 50%. Degradation means 50% of basic strength retention, 100 days versus 42 days and 35 days, respectively, for the polydexanon. And the mass absorption means staying at the material for the monomax 390 days versus only 210 days. So at the end, the monomax is ultra long-term absorbable monofilament suture material with a high elasticity and flexibility and initial strength and constant degradation rate, and seems to be an optimal material for the closure of the midline. This was also the hypothesis to start with the ESTER study. This is the protocol published 2015. You see the effective stitch technique on the occurrence of incisional hernia after abdominal closure using this new material. The study protocol was, you see, the international multi-center, double-blinded, prospective randomized controlled two-arm study in 9 centers, 2 countries, Austria and Germany. And the sample size was in total 468 patients. Indication, elective primary median laparotomy in using this short stitch technique. And there was the hypothesis that the short stitch technique should decrease the rate of incisional hernia rate after 1 year by 50%. The primary variable was 1 year post-op, assessed by ultrasound. And now I will present the 1 year data in a few minutes. Suture technique, short stitch technique using this monomax USB 2.0 with a 150 centimeter of length. The needle HR26, a small needle, continuous single layer, only fascia including in the suture line. Stitches were placed 5 to 8 millimeters from the wound edge at the interval of up less to 5 millimeters. Suture incision length ratio was at least 5 to 1, not 4 to 1, 5 to 1. Starting in a healthy tissue means distance to the corner was 1 centimeter outside the incision, and the stitches should be visible as a sign of less tension. The large bite technique was done by monomax USB 1 with a loop suture, 150 centimeter length, and a big needle HR48. Again, only the single layer technique was used, and the stitches were placed in the common way, 1 centimeter for the wound edges and the interval as well, 1 centimeter. Suture to incision length ratio 4 to 1. In this group, we also started in a healthy tissue outside the incision, and we had in the group as well a small tension. We started and ended in the short stitch group using a self-locking knot. Why that? I will show that in a few minutes in my short video, because this high elastic material is prone to have overstretching, and then it could be the complication of a rupture of this material. Therefore, you should use a self-fixating knot at beginning, at the end of the suture line. Of course, it's not only key to close the midline in the right way, but also to open it. That means to have to prepare the linea alba and dissect the fatty tissue that you see exactly the midline, the crossing fibers of the linea alba, that you can do an exact midline incision without splitting anterior and posterior sheet of the rectus muscle. And then you, of course, you do, as I already showed you, the distances in the small bites technique with low tension. At the end, you should have a suture line visible like this, you see, without high tension. So, of course, it's of main importance to know how you did it. That means at the end, you measure the incision length, the number of stitches you have to count, and the remnant material, or respectively the applied material. And if you look at 20 centimeters of incision length, you should have at least 44 number of stitches, and the applied material should be at least 100 centimeter of thread. Now coming back to my ESTO study, you see the baseline demographics and clinical characteristics. We included 250 patients in the short and 210 in the long stitch group. There was very similar contribution of gender and the risk factors, smoking, alcohol consumption, ASA classification, and comorbidities. I will go fast through that and show you now the type of surgery. It was predominantly done colorectal surgery, followed by gastric, pancreas, and small intestine surgery. So coming now to the details of suture technique, you see the wound lengths was in both groups very similar, 21.6 and 31.4. The sutural length to wound length ratio, the aim was to have at least 5:1. We had 5.3, and in the long stitch, it was recommended to have a 4:1, means 4.0, exactly what we aimed to have. And the duration of the fascial closure was, you see the difference was significant, 40.9 minutes versus 9.23 minutes. This was significant. And now looking to the adverse events, we had a burst abdomen complication in the short stitch in 3 patients and in 10 patients in the long stitch. This failed to be significant, but was quite different. Regarding the surgical site infection rate, it was very low, 3.2 versus 5.2. Superficial, only 1 patient in each group with a deep infection. Hematoma, seroma, wound healing disorder was without any significant difference. This anastomotic leakage rate was higher in the long stitch group, which was not associated with the technique of the closure. This was just seen in this study. Hospital stays, you see, were significantly different. The short stitch group was significant less, 1.5 days shorter. Coming now to the, we looked at the risk for burst abdomen and wound infection. We did multiple regression models, and we found a 7-fold decreased risk for the short stitch group regarding the risk of burst abdomen. Looking especially to the duration of fascial closure, we found a reduction of almost 10% for every minute. That means you should take your time for the closure technique to do it in the right way. And looking to the wound infection, we found a 3-fold increased risk for patient with a BMI more than 30 kilograms per square meter and a male gender. Now coming to the announced the 1-year data we published in the British Journal of Surgery in August last year. We had in the short stitch group incisional hernia rate of 4.24, and in the long stitch 8.23. This was not significant, but very low. You will see we have done a comparison with the other trials. If you look at the incisional hernia inclusively burst abdomen, then of course we had significant differences seen with 5.95 versus 13.7. Now coming to the another quality of life assessment we did in the ESTO study. This is, you see the baseline compared to the 1-year results regarding the Eurocall 5D quality of life scoring, mobility, self-care activity, and pain and anxiety was significantly better for the short stitch group. Now, comparison between Milburn study stitch and ESTO study, you see the surgical site infection rate was the lowest seen in the ESTO study. In the long stitch, 5.7 versus 3.7 in the short stitch was not significant. The highest was seen in the stitch trial, was 23 versus 20, and Milburn was significant, the only study showing 10 versus 5%. Incisional hernia rate, you can see now the data 18 versus 5.6. In the Milburn study, stitch trial, very high for the long stitch, 21 and 13 after 1 year for the short stitch. We had 8.2 as already presented, and 4.2 means we had in the long stitch group less than in the small bite group of the stitch trial. Now, looking at the forest plots with inclusion of all 3 studies after the ESTO study, you find cumulative incidence of incisional hernias of 8.19 versus 16.8. This is, of course, significant. So I would like now to show you what's about emergency laparotomy should be used as well. The small bite technique, there's a nice paper coming from Denmark, and you see the method was to use this small stitch technique with a historic, and compared to a large bite technique, the historical cohort, you see in an emergency setting. And you see after 52 months of follow-up, they had a reduced rate of descent, means burst abdomen, from 5.6 to 2.2. And the incisional hernia rate was also decreased from 27 to 15%. So the risk factors in this regression analysis was a BMI at least of 30 and more, and a standardizing method of closure reduction of incisional hernias. So keep in mind, if you use it, you can, in emergency setting as well, have better results regarding burst abdomen and incisional hernia in the long term. What about the guidelines already announced by Professor Köckerling? This was the first published guidelines by the EHS, you see, 2014. This was in Edinburgh at the meeting. They published, the publishing was 2015. And we had first time a grade scoring, and you see statements and recommendation. The first statement, respectively recommendation regarding the mesh, I come to the point later on, was to use elective in the prophylactic mesh augmentation for elective midline laparotomy in high-risk patients. Was a weak recommendation, a suggestion which mesh type, which mesh position, which type of mesh fixation. There was no recommendation regarding the type of mesh, no data, and therefore no recommendation for the position, and no recommendation about the mesh fixation. So now I would like to show you, and of course at that time we didn't have the prima trial and another trials I will show in a few seconds. And I would like also to show you the updated guidelines for the closure. Now this is another point we had to address. This are the guidelines published recently in the British Journal of Surgery in August by Eva Derenberg. And you find on this in these guidelines the question: what is the preferred strategy for closing a laparotomy? In the statement, there was regarding the available studies, no superiority of the specific suture material or continuous versus interrupted suture could be shown. Combination of a continuous small bite suturing technique with a slowly absorbable suture reduces the risk of incisional hernias. Leading to a recommendation to use a continuous small bite technique with a slowly absorbable suture is suggested for closure of elective midline incisions. But you see, quality of evidence low, recommendation was weak. So it was not really a change of recommendation, even less than it was 2015. But the ESTO study was at that time not included. So coming now to the already announced mesh placement, which is another part, of course, of my talk. And I would like to show you the most important study published by Aran Charam, 2017. This was a multi-center trial regarding the so-called PRIMA trial, comparing patients with a midline laparotomy. 480 patients were enrolled. Risk factor was aortic aneurysm patient and body mass index of 27 or higher. There were three groups: the primary suture group with large bite using the loop suture of polydexanon. Onlay mesh was the first treatment group using as well the large bite with the optilinear mesh with fibroclue fixation, and the other group was the sublay mesh, again using optilinear mesh and having a fibroclue fixation. After 2 years of follow-up, there was found incisional hernia rate of 30% in the primary suture group, 13% in the only mesh, and 18% in the subly mesh group. So you see the best results were seen in the only mesh group. This is quite different from our feeling for the best option to have a repair, but this is not a repair for incisional hernia, it's a prophylactic mesh. So you have to divide these two different issues. Seroma were found more frequently in the only mesh group. You see 18% versus 4.7 and 7%, but this complication did not lead to significantly more readmissions or reoperations. Another study was published by Philip Moisums, the EHS president, in the Annals of Surgery 2016. It was the PREMAT trial, prophylactic mesh augmentation in midline upper risk for abdominal aortic aneurysm treatment. And he used in this multi-center randomized controlled trial in 120 patients, a retromuscular mesh augmentation based on a large bite closure. You see Ultra Pro was the mesh he used with a width of 7.5 centimeters. And after 2 years of follow-up, the conventional closure group had 28% of incisional hernias, and in the mesh augmented group, there was 0%. Now it's recently published the 5 years data, and they're still having, I can report there's still 0% of incisional hernia rate in this group. And the conventional closure group is now on about 42%. There was a almost doubled situation after 5 years. And you see there was no adverse effect regarding the mesh augmented reinforcement. But the special thing is, we can discuss afterwards maybe, that of course, these were not vascular surgeons who did the mesh placement into retromuscular space. These were trained surgeons, so-called closure hernia specialized surgeons, which were coming to this operation and did the retromuscular mesh placement. You see there was increased time for doing this kind of mesh placement was 46 minutes versus 30 minutes, and this was significant. So coming to another important randomized control trial by a Spanish group led by Garcia Urena and published 2015. This was in colorectal surgery using optimally mesh elastic again, based on large bite technique in 4:1 suture to wound length ratio with a 5 centimeter straps width, and you find they found after 24 months, you see in the incisional hernia in the non-mesh group 31. Again, it's about always the 30%, and the mesh group 11.3. Seroma formation, evisceration means burst abdomen, and infection rate were not seen different. So overall systematic complications as well. So you see, this was nice data, because we have a lot of discussion to put a prophylactic mesh in colorectal surgery regarding infection rate, and there was not seen any difference in this RCT. Another point is to use, you see in clean contaminated field, this was also a prophylactic sublay non-absorbable mesh by a group of Italy, British Journal of Surgery, published 2021. You see this was urgent midline laparotomy, as well. You're having a clean contaminated surgery, large bite, sublay with a Bitex pro-grip mesh, follow-up of 24 months. And you see hematoma was not significant, superficial wound infection rate, as well, deep wound infection, one mesh removal and deep infection in the mesh group. But after 24 months, you had a 21 versus 6% of incisional hernias. This was significant, and in the multivariable analysis, this was also significant. So now coming to the question, what is the best placement, means mesh position, if you have a not a treatment, but a prophylaxis in midline closure. So there is a systematic review and meta-analysis published 2020 by Ahmed. There were 26 studies enrolled with more than 3,000 patients, and you see the incidence of incisional hernia was in all these years up to 1 to 5 years was significant, and you see the prophylactic mesh placement was associated with increased risk in seroma formation. We know that already. Chronic wound pain, this was new, but there was no significant differences seen in post-operative hematoma, etc., site infection rate and wound defense. So now coming to the question in the subgroup analysis, the incisional hernia rate after 2 years regarding the position of the mesh, and you see the only mesh group had a 10.5 versus 26.2, followed by the next group of retrorectus mesh position, 11.2 versus 28.4. This was significant, but not as good as the group of onlay mesh. And the preperitoneal mesh had a not significant result with 13 versus 20%. And the intraperitoneal mesh was significant, but had a high rates of incisional hernias, 16.8 versus 38.8. So the best option was to have an onlay mesh. You see there were the best results in this meta-analysis. So another thing I would like to show you is the implementation of a protocol to prevent incisional hernias in high-risk patients. This was done by a Spanish group published by Pereira Rodriguez 2021. And you see there were prospective data of elective midline laparotomies. And looking at the incidence of incisional hernia and fascia dehiscence means burst abdomen, they used mesh versus suture, and you see small bites and also non-small bites, large bites. And at the end, after you see almost 30 months, there was a significant less fascial dehiscence in the mesh augmented group and significant less incisional hernia rates. So they did a propensity score matching, and you see again the burst abdomen complication was significant less. Incisional hernia rate was as well seen as significant odds ratio. And comparing suture techniques by subgroups, both mesh groups had better outcomes. That means small bites or large bites augmented by mesh had better results to the control group. And obviously, this was the most important thing out of the study. The prophylactic mesh was the main factor related to the reduction of incisional hernia. So now I would like to show you regarding resorbable biosynthetic meshes in prophylactic use. This was also coming a randomized control trial by the Italian group of Pizza. They used a BioA, you see in a sublay position with a 3 centimeter strip, and midline laparotomies at least 10 centimeters, clean contaminated and contaminated fields. And they had 2 groups, the BDS loop, again, this was a large bite, and the treatment group with a BioA strip. And after 2 years, they had a 22% of incisional hernias in the primary closure group, and you see 6% in the BioA group. Positive pain, morbidity, and mortality was not significant. So I think this was quite promising, but we have no data in the long term, and this is up to now the only randomized control trial using this resorbable biosynthetic mesh in prophylactic use. So coming now again, this sorry I mixed these 2 slides, but again would like to show you the old guidelines. This from 2015, respectively 2014, regarding the closure. At that time, we had a continuous suturing for closure of midline wall incision elective surgeries recommended was strong. You saw there was a decrease after recommendation to a weak recommendation. Peritoneum should be not used in an extra closure. This was not recommended. This was weak. Then again, a single layer aortic closure is suggested, weak. 4:1 suture to wound length ratio was weak, and the small bites technique as well. So, you know, of course, this didn't change since the stitch trial was now included, but the ESTO not. So we have to discuss. Hopefully we have then the next update will change this recommendation, but nowadays we are not, the evidence does not allow any strong recommendation. Regarding, this is the update now, I showed you regarding the closure, regarding the prophylactic mesh, I showed you already. And but this is the new recommendation didn't change anything. You see, there was the only thing was the placement. You see, this was again low, weak, very low quality of evidence, and weak recommendation to use it only or retromuscular. At the first guidelines, there was no recommendation regarding the placement. Where should the augmented prophylactic mesh placed? And the best option, but now we know that only in retromuscular is suggested. But now this are the recently published data. We can use the prophylactic mesh, of course, for the reduce the risk of incisional hernia. So this is the end of my talk. I hope you have a lot of questions, and I would like now to start with the survey, with a multiple choice question on I prepared for you to answer. This is question 1. Which kind of elective midline closure should be preferred? You see, there's the question: large bite with lip suture, small bite with suture O, or a small bite with suture 2O. Okay. Yes. That's still going on. Yeah, small bite with suture size O is okay, 28, but of course the option where the best option were to use a 2O. This was 61%, together 89%. This is right. Okay, next question. Which suture to wound length ratio should be used in small bite techniques? At least 5:1, 4:1, 6:1, or 3:1. Okay. 4:1 is the standard suture to wound length ratio, and 5:1 seems a little bit better based on the ESTO study, but both are right. Means we have 95%, which is of course the right answer. 3:1 would be too less. So coming to the question 3, please. Which suture material is recommended for the closure? Monofilament, non-absorbable, multifilament, non-absorbable, monofilament late absorbable, and ultra late absorbable monofilament. So, okay. Yeah, of course, you know that monofilament late absorbable or the ultra late absorbable are right. You should use nowadays, of course, the ultra late absorbable, which means that should be based on our data from the ESTO study, maybe an advantage for the long-staying support of the healing of the midline. I'll just would show you now. Maybe come back. I will share my my screen. Will present you now a video for the closure. Okay. This is just to show how to do that. This is the midline incision. You see, this was a patient with a hemicolectomy and with a BMI more than 27, and you start to dissect the fatty tissue from the fascia, from the linea alba, and you should start always at the umbilical stalk, because this is the right place to get into the right exactly midline. And of course, if you plan a mesh in this case, then you have to dissect the width at the beginning, not at the end. Now this is the opening, starting at the so-called, I call it natural orifice at the umbilical stalk. First stage in healthy tissue to have a good result using, this is a Monomax. You see, I already told you, you should start with a self-fixating knot to have less trauma, not only to the tissue, but also to the threads, which are very high elastic to prevent the overstretching. You see this, there is a splitting on the right side now. So you have to take the first bite to the posterior sheath and then to the anterior sheath. The best option is, of course, to be exactly in the midline, like now, you see, to have the stitch only in the fascia. Now, less tension, you see the threads are very good seen at the closure line, and you're coming down and you see this is exactly 5 millimeters from stitch to stitch, and you do the Aberdeen knot at the end of your suturing, self-fixating knot, and now you can place the mesh. This this mesh has a 8 centimeter width, and the overlapping is as well on the cephalad in the lower part, 4 centimeters. And you see there is the fixation is done by Monomax, the same material as the mesh. So I would like now to come to the survey we did for the EHS members online. The question were, which closure technique do you routinely use after elective midline laparotomy? There were almost 80% using the small bites, large bite 20%, and 3% still interrupted sutures. What suture to wound length ratio do you use in small bites? 88%, at least 4:1, and 5:1, 12%. And reasons for not implementing small bite technique, the not trained group was the highest group with 34%, time consuming, don't trust, insufficient data, 7%. So that leads us, or me, to stress again the topic of workshops and hands-on training. This is of main importance to show how to do the midline incision and the closure technique, and to start with the right way under, of course, instruction. So this is one part, and I come now to my take-home message, the last 2 slides. Why should we use long bites technique in elective midline? Because you have a uniform distribution of suture tension to the tissue, less tissue trauma, you know, from the experimental data, and improved collagen synthesis, synergetic effect with the elastic monofilament suture material, and less incisional hernia rates. But you have to invest time for the preparation of the linea alba, and the closure time about 5 minutes more. We have already the discussion especially in Germany and Austria, we look at the colorectal surgery and the discussion about minimal invasive techniques, we have still 60%, 55 to 60% are done in an open approach. That means you have a midline incision, and therefore we have to take care about to do the right closure with a small bite using at least 4:1, better is a 5:1 ratio, using a long-term resorbable monofilament elastic suture material. If you follow the ESTO study, and patients at risk should have not only a small bite technique, but also a prophylactic mesh. And the combination of a small bite technique and prophylactic mesh seems the best midline closure for patients at risk. That's it. That's my talk, and I'm eager to have some questions from you to answer.
Yes, thank you very much, René. Great talk. A lot of important information, making decisions easier now for us. The last point I would like to discuss with you, you said the best technique now is small bites and additionally a prophylactic mesh. Do we have really studies for that?
No, you're completely right. There are two studies. One is running in Germany, but still going on. That's really a pity. We have a lot of augmented mesh, prophylactic mesh studies. I showed you the most important, but all were done with a large bite technique. And I'm really convinced if you combine both techniques together in patients at risk, you will end up with better results. So that's for sure. We have just one study by the Pereira Rodriguez with this implementing of small bites and mesh placement. And in both techniques, there was sufficient data to support the prophylactic mesh in patients at risk. But of course, there was too low. The number was too low for comparing small versus large bite. This was not enough data, and the comparison was not sensible to make a difference. But they are going on studies. I know that we have to wait for it. But nowadays, I would. This was also my last slide. Combine small bites with a mesh placement in the onlay position. Why that? Because the complication of seroma, maybe, of course, this might be a complication, but you do not destroy the place for incisional hernia repair. If there is a problem in the future and you have to repair incisional hernia, you have still the retromuscular place, the space there to put the mesh in. And this is one of my recommendation, not to burn bridges for further surgery.
But I think you agree that we need these studies urgently. So good randomized trials comparing small bites versus small bites and prophylactic mesh, or not? Yes,
absolutely.
We
absolutely.
do need the studies. Oh,
yeah, absolutely. You are completely right. This is only a suggestion to say that should be much better to have the combination of both. Of course, we will. There's a lack of data. We have to wait for the RCTs. They're running. One is done by a German group, and still waiting for that.
And there's a question from the audience. If we don't have monofilament long absorbable sutures, can we use a non-absorbable monofilament sutures?
Yeah, there is, of course, we have the data from DINA 2010, and there was in August already stated that the non-resorbable suture material have some flaws and complications in the long term, means suture sinus, and therefore the recommendation at that time was already to use long-term resorbable monofilament suture materials. And this is also in our recommendation of the guidelines, the updated guidelines. There's no change. if you don't have a monofilament long-term absorbable suture material, maybe then you should use a non-resolvable. That's of course right, but in any case, it should monofilament structure. And of course, I told you the elastostyle high elastic material is quite nice to have it in combination with the abdominal wall compliance, which means you have less tension on the suture line.
Can you a little bit more comment on the role of the opening of the abdomen in the whole concept of avoiding incisional hernia development? So I think the whole project starts at the beginning of the operation.
Yeah, right. Thank you for the question, for the comment. Yeah, it's really of main importance to it, or that's not only the closure technique, also the opening technique, to do it in the right way. So that means not to cut in, to be not exactly in the midline. If you have really the linea alba prepared for the incision, you start at the umbilical stalk. There is also all kinds of patients you will find a small defect. That is the umbilical stalk, and you take down the stalk and you find there 5 to 7 millimeters defect. And this defect is the natural orifice we use for the notes, for instance, in the old days, and for of course for all the different techniques for the trocar side. And you can start there exactly in the midline. And if you have freed from the fatty tissue, the linea alba is quite nice to see, the crossing fibers, and you can have the incision exactly in the midline without splitting. I showed you in my video, there was in the upper part, there was a splitting. And if you have a splitting, then you have to stitch. The first stitch comes to the posterior sheath without muscle, of course, coming to the anterior sheath. And then you can follow again your stitches as you used to have.
There's another question. What about the lower third of the midline? Is it sometimes difficult to open the abdomen correctly in the midline? What should we be aware of when doing the incision? And are there any tips for closing the midline if the incision did not go so well?
Yeah, I just told, in the lower part, of course, there's no posterior sheath. And as I mentioned, this is in the lower part, the tension is not as high as in the upper part, means above the umbilical side. And if you failed the midline and if a splitting, then I already told you should have a stitch starting anterior posterior sheath without muscle and the contralateral side as well. But the best option is, of course, to be exactly in the midline. And this can be done only if you dissect at the beginning, before you have the incision. You start to prepare the linea alba, means you remove the fatty tissue from the linea alba. That's is my recommendation.
Yeah. Another question is, what is the role of the different fixation techniques of the mesh if you use a prophylactic mesh? So it means glue versus suture versus self-fixating meshes. So what is your opinion about that?
I think there's no difference. We had a glue fixation in the primer trial. This was the big trial of Eva Dernberg. We had this was one study was done by hooks. This self-fixating mesh was also without any problems. And we have a running study now in Austria using a suture fixation in a distance of 3 to 4 centimeters. It's okay. You can do whatever you like. I think it makes no difference. The width should be at least 6 centimeters. We do it now in Austria with 8 centimeters, means an overlap of 4 centimeters each side. I think this is also important to know. If you have too less overlap, means 2 centimeters, that might be too less.
Yeah. Sometimes on the conferences, there's always a discussion concerning closure teams.
Yeah.
Is it really the right way to go to create closure teams?
Yeah, I don't know.
Because I would say closure team alone is not sufficient. Then I would say opening and closure team.
Yeah, you're completely right. That would be the best option of an opening and closure team. We have now started in the university in Leipzig, where the closure team means trained residents close the midline at the end. We will have data on that, how it works, but we know if they are trained, if you are trained, you can do it in a better way. If there's a big operation after long-lasting 3-4 hours, of course, it takes time to have a small bite technique at the end. Maybe this might not the best option to have a perfect closure. So this is the idea, to have a closure team. But you're right, of course, the initial start of the operation to do the right incision in the midline is key for having less complications at the end of the operation. You're right, but nobody knows how to achieve this good results. In the study, we trained all the participants, all surgeons, and then started with our study afterwards. So that means they were used to have the material, the stitches, how to close, and of course open as well the midline. And therefore, this is one part of our study. I would be very, very convinced that this is key for success. Means to train and then to start with a study and doing all the right technique, the standardized technique. And of course, there's a lack of training. We saw that in the survey of the HS group. They were not trained, 34% were not trained to do the small bites. And if you start without training, maybe you will fail. You will have problems with the 2O material, very thin, overstretching, ruptures, burst abdomen, whatever. So we have to train this small bites technique. So this is my advice.
Most of the studies performed at a patient collective of colorectal surgery. Does that not really play a role in the outcome of these patients? Do they not have more wound complications and therefore more incisional hernias?
No.
Is it always a technical question, or sometimes also a problem of complications of the wound?
Yeah, we didn't see any association between infection and incisional hernia rates. We know that, of course, that might be a problem, but we didn't see that. First, we didn't see that in the ESTO study. We didn't see in the mesh placement study in the colorectal surgery of Miguel Garcia Orena. This was the Spanish group, which did only colorectal surgery patients enrolling in this trial. And even there was no significant difference seen between the infection rates. So that means you can, in the meta-analysis as well, so you can use in colorectal surgery, of course, small bites and meshes prophylactically. This is my advice, and there's enough data on that, so you don't have any concerns about the infection rate or the risk of whatever, having complications in the long term.
Okay, René, the hour passed by very quickly because of the interesting topic you presented us. So thank you very much. It was a great, a great talk. So it was fun for us. We have learned a lot, and I'm sure all the participants will have profit from your talk. And hope we have you soon again for another topic also, that we can hear what is the opinion about that. So René, thank you very much.
Thank you.
I go on and show some information to the participants what is next. On the 9th of March, there is a colorectal or coloproctology topic as UEMS webinar on anal fistula. On the 13th of April, we hear about the endocrine registry and the outcome of endocrine surgery in this huge project. And we also have our next examination, EBSQ examination, abdominal wall surgery. The deadline for application is the 21st of March, 2023. The examination will be in Barcelona the day before the annual meeting of the European Hernia Society. And we also have on the 6th of May, the EBSQ exam in trauma surgery. Deadline for application is the 1st of March, 2023. And please follow us on Twitter and other information channels in the internet, and keep you informed about all our activities. Thank you very much for your participation. It was a pleasure to meet you in this webinar, and hope we meet again soon. Thank you very much.